Brilliant. Okay, so first question. So patients wondering if we know MEN1 is well, we see it as a fairly stable disease and something that we've got quite a lot of. It's very much within our handling, I guess, in terms of monitoring and that sort of thing. She's wondering why, if we can consider it stable, then suddenly things become very unstable very quickly. And is that just spontaneous, or is there do we know if there's a trigger per se?
Okay, so the trigger is the same as any other tumor, right? So in any other patient. So normal people get various cancers, and cancers happen because of a random mutation, okay? And our DNA is being exposed to sunlight, radiation, unknown things, and random mutations happen, right? Now, of course, we have got 2 copies of every gene. So if you have a mutation in one gene, the cell's okay, you need to have 2 mutations for a tumor to sort of develop. Now, if you have the gene for MEN1, that means the cells of your parathyroids and your pituitary and your pancreas, the endocrine ones, have already got 1 mutation. So that means those 3 groups of cells just need 1 hit of randomness and they'll become tumorous. Now, luckily, parathyroid disease is benign, and we better have no disease at all, right? So I could get primary hyperparathyroidism, but I'd need to have 2 unlucky mutations, whereas you would need only 1, and that means all your parathyroids are already just waiting for 1 hit. And when that happens, so let's say your left upper parathyroid gets a hit, then it will become tumorous and you're hypercalcemic. Now, because your other 3 ones have also got that mutation, there's a chance, random, that another one will take off as well, which is why we know that you're at risk of 4-gland disease, but actually you're only at risk at 1 at a time. And I'm also at risk of 4-gland disease, but the chance of me getting even 1 is quite remote. So some healthy people get 1 and that's it. Some get 2. But if you've already got 1 mutation, then your chance of having all 4 in the course of 50 years or 100 years is quite high. So what happens is that we're all absolutely fine. All our cells are not tumorous, but they're sitting there with the gene that's ready to become a tumor with 1 hit in those 3 organs. And the minute you have a hit, that cell starts to grow and it's a tumor. And then it's not like lots of different, it's one thing, but lots of things happen to us. So we have then got to check the calcium, check the pH, plan the operation. So to you, it seems like many things suddenly happen. And then when we sorted it, it all goes quiet again. And then another random mutation might happen in your pancreas, in which case you have the tumors of the pancreas, which are obviously less good. They're more troublesome because they are more often malignant actual cancer, which is why we keep measuring and scanning you to see if, because when it starts, any tumor starts quite small. So we'll scan you every 2 or 3 years, because we work out that it takes more than 3 years from a random hit to real trouble. So if we screen you every 3 years, because what you want to know is what you have before you get symptoms. Because once you've got symptoms, in the case of the pancreas, it's a bit dangerous. So we don't want to wait till so we do an MRI when you're well. And if it's normal, then we go, great, that was a waste of time maybe, but no, we know then for the last 3 years, you haven't had a random hit, and you might not have a random hit for 9 years or 12 years, but then one day it might happen. Some of you never have a pancreatic tumor, very lucky, and others, like yourself, have already had one. Does that answer your question?
It does. So when you talk of it as a hit, do we know what causes that hit, or is it that completely spontaneous?
Well, it is a mutation of DNA. So I suppose it's worth saying that all of us have quite a lot of continuous mutations of DNA in lots of cells all the time. And then there's a DNA repair kit that's going around your body, repairing the damage. And so it's when that fails to happen that you actually have a tumor. So quite a lot of things have got to go wrong for one cell to go on a tumor. Once it's happened, then it takes off. So if you ask me is there anything that, I know what you're asking, is there anything you can do to prevent it? No, because we don't know what it is on a particular cell, but for example, people who are more exposed to radiation have it happen more often. So we know that that's a risk factor. That's the only one that we absolutely know, because random mutations are always happening. So I guess the word is truly random.
Truly random. Okay. Yeah, that does make sense, actually.
I think one of the things that we will ask ourselves is, why did it happen to me? Okay, that is, why have I had any kind of tumor at this point in time? And we try and link it to something in life. That's what we do a lot of. So we think, oh, I'm a bit unlucky and now this has happened, I've got this tumor. Now, if you look back in time, you will find something that's happened to you. It probably is not relevant, but we like to link them. And so a lot of my patients say, I had a really, really stressful month with my boss, who was giving me a really hard time, and then I got this tumor. Now, they're probably not linked, right? But it's comforting to make that link sometimes and blame it. And so I don't deny it, but I think it's not the case, because I see a lot of people looking back, and if you get in some parts of the world, you have soothsayers. Who are the soothsayers? They read palms and things, okay, and they sort of guess as to what is quite likely to happen in life, and they're quite good at it. And they're not doing it out of malice. They actually believe that it's right, and they look at events in life and they link them, and they say, sometimes wrongly, this has happened because you did this bad thing, okay, and that's why you've had this unlucky event. That's not really true, but it does, a lot of people believe it, and it does help people to kind of square the circle and think, but it's probably not an evidence-based thing.
Okay, that's
very, it's a bit vague, but that's what I think.
No, really interesting. Yes, I guess, from my point of view, or my experience, I should say, to be stable or unstable, it feels like something that you can grip onto. And as you say, right, when something random comes along, it's like, well, why has that happened? And obviously the brain being a sort of problem-solving machine is like, I wonder what's going on here, and starts to do the linking. What actually, that leads onto another question, which I was going to get onto later, because you mentioned stress. And I mean, people are talking, experts are talking now about, links between stress and, environmental factors, all sorts of things, and certain diseases. Does that include MEN1, or, as far as we're aware, the mutation on the gene is something totally separate?
The difficulty we all have is defining stress. Right? Stress for one person is enjoyment. The same stress for one person is a bit of a challenge and fun for others. And there are different types of stress. A really important definition of stress as it applies to medicine is something that's life-threatening. That's a true stress. So, for example, pneumonia. Pneumonia is very stressful. Pneumonia demands a big increase in oxygen requirements. The immune cells have got to work hard. And if you don't do it, you die. That's a true stress, right? And so some people call that a physical stress, or maybe a real stress, right? So what's the other kind of stress? The other kind of stress is the ones that are not physical, but upset you. And it's stressful to be shouted at. It's stressful if your boss tells you off. You get some of the same symptoms. You get palpitations. So the kind of stress that is life-threatening is important, because that has impacts on your immunity. We don't honestly know, I can't pretend I do know, how these different kinds of stress that you're talking about, in other words, being shouted at or being unhappy, affect your immune system. It might do, because I mean, the actual truth, we don't understand how the brain works. Okay, I mean, what is it that if you were to win a large amount of money makes you happy? What chemical in your brain says, God, that's fantastic, or you get a prize? Okay, and then everyone says, well done, and you feel good. There's a chemical, probably, I wish we could have that chemical, okay, that is positive. And on the other hand, if things really go wrong and you have some very unfortunate bad news, you feel terrible, you feel emotional, you feel upset. We don't know what that chemical is, okay? Now, sometimes those changes are within control. And one of the things I have noticed is that when things happen to you, if you feel in control, then you come out of it much better than if you feel you're out of control. And so what I'd recommend is that if you can control the situation, you try to take control of it. Now, sometimes I've certainly spoken to a patient who was very unhappy at work, and he said, do you think I should resign? And I thought, that's not a medical decision, right? But he did resign, and I'll tell you, he's been the happiest man since then, because that was his stress. That was his stress. Now, other people find that a challenge and will be fine with it. He's got a nice new job. He said, I just wish I'd done it before. I don't think it'll affect his chance of getting cancer, but he's certainly much happier. And so that's always a good thing.
And I think that's, something that we don't often, even as patients, we don't often take into account is, yes, maybe I've got this condition, but actually, I've got this condition and I can still be happy at the same time. Or, it's like, one doesn't kind of necessitate the other in terms of, having the disease and therefore really, really struggling versus having the disease and still realizing you can have an amazing life. I mean, I'm definitely grateful to be able to say that. But yeah, I definitely take your point. And interesting about the different kinds of stresses, what we consider stress now, modern day, being shouted at or deadlines or whatever versus beforehand.
Isn't it? Because if you are shouted at, you can feel your heart beating faster. That's a stress response.
Yeah. Absolutely. Yeah. No, it's a really interesting topic. It always brings up a lot of debate, actually.
Yes.
So you mentioned cancer. There's a question here. We know that aging increases our risk of cancer. Does this happen in MEN1 too, assuming that replication, I think that means replication of cells, is higher and can lead to faulty genes?
The answer is yes. Yes. So what's happening is mutations are happening randomly to all our cells, and it's cumulative, right? So let's say today I get a mutation in a cell, and that mutation happens to be harmless. I'll be okay. Now, as I live my life, that cell will keep getting random mutations, and they accumulate, and then one day one of those mutations is one that causes cancer. So it adds up over time. So you can get cancer when you're 10 or might even younger, but obviously the mutations add up and add up. So if you plot a graph of incidence of cancer, it definitely goes up with age because we're getting more and more mutations. Because if I get a mutation, it's happened, and they get another one, it adds to the other mutation. So the answer to your question is age is definitely an increased factor. And it's the same with MEN1. So parathyroid disease, you start off with non-parathyroids, and there's actually a publication looking at the incidence of when people develop primary hyperpara, and it starts at about 15, but it can be 30. Almost all patients by the age of 50 who have MEN1 have had one at least parathyroid adenoma. So it accumulates, and there's a graph, in fact, plotted by it's Rice paper. He was the last author, and he published it when I was a junior doctor, so quite a long time ago. But and Dorothy Trump was the first author, and she wrote this paper where she actually went around the country meeting lots of MEN patients when it was a new disease and we didn't know the gene, and was plotting the number of people who had got it and plotted their age, and she found that by the age of 50, everyone had got it. Which means that if you haven't had a gene test and you have a family history of it and your calcium is normal when you're 50, you probably haven't got MEN1. Because you got to 50 without a mutation, and her evidence is that everybody by that point had. Now, there's going to be exceptions to that rule, but it's quite a good rule.
That's interesting. Yeah, that is interesting.
So the answer to your other question is don't get old, okay? Age is definitely a risk factor for everything in life, unfortunately.
It is. It is. Yeah, it's interesting because actually my grandmother, I think, got well into her 70s before she had any problems with MEN1. I know my late dad and aunt had them, around their 40s, and then my sister and I have had them, really early on, kind of early teens. And there's this part of me that's, thinking, does age have anything to do with it? Obviously, that sort of shows the reverse. And part of me is now thinking, does the gene kind of mutate? Does the MEN1 gene itself, are there kind of different mutations as we go through time?
Yes. So in an individual family, the same mutation is clear. It doesn't change. But what does change is the way that we handle it. So in your grandparents' day, getting a calcium was a huge affair, measured. If you want to get a calcium, you had to get a form and get a special sample. So we didn't do it. We just didn't do calcium. The blood test that we used to do 50 years ago was sodium and potassium. That was all you could get. You could get a calcium, you had to, get a special laboratory machine to do it. So as a consequence, a lot of people with hypercalcemia never knew. They feel okay, they feel a bit unwell vaguely, but so do we all. So I suspect that your grandmother had undiagnosed hypercalcemia for a long time, but didn't know. That's almost certainly the case. And then in the next generation, we're looking a bit harder. And so you diagnose at 40. Now, the minute you're born, we're sequencing your gene. And the minute we know you've got the gene, you're on to tests. So I think that's called anticipation. And it's anticipation, in this case, clinically. There are some genetic anticipations that happen, but not in MEN1. There are other conditions where the gene does become more aggressive generation on generation, and that's a genetic anticipation, we call it.
Right, that's really interesting. Okay, I've cleared that. I had a question off the back of that and it's gone out of my head, so I'm going to move on to another one and hope it comes
okay,
back.
It'll come back, yeah.
So someone has asked, is there anyone to represent patients when guidelines are either changed or updated? How much oversight do clinicians have? For example, do teams in Oxford discuss cases with teams in London and vice versa?
Yes, I definitely. So we have regular meetings. We have a meeting at the Hammersmith every December, run by the endocrine surgeons. Mr. Palazzo is but he started it about 25 years ago. And we have surgeons and physicians from all over the country. And now on Zoom, we do on Zoom as well, transmitted to all the consultants around the country who are interested in neuroendocrine tumors and in parasite disease, and discuss the different options. So we have MDTs that go national, which is, it's called the Multidisciplinary Endocrine Symposium, and it's for surgeons and physicians every December. And in fact, MEN patients used to come to it, but they got a bit bored, I think, because it's not fun. It isn't these really boring talks. It sounds boring. It's very interesting to us because it's all about calcium and sodium and potassium and things that biochemists find interesting, but maybe not so. I mean, certainly there was, when they were starting to do adrenalectomies through the back, there were some patients who had some really interesting views. So they were there and they were making their point. When it comes to guidelines, right? So guidelines are a very, very important mechanism to get things right. Okay. So what happens is we all do a bit of research. Okay. And so there's research happening at Charing Cross and there's happening at Oxford. There's the Endocrine Society meeting, which is every November, where we present our research to each other and then we publish it. Now, the guidelines come out from, we're very lucky in the UK, we've got NICE, the National Institute for Clinical Excellence. And what they do is they review lots of papers and they actually look for evidence that things will make a difference. So they really want to not just say, let's just do this because we think it's a good idea. They say, in Oxford, where they did this went well, and London didn't do that, so we're going to recommend that everyone does the same thing. The guideline writing committee is run by the Royal College of Physicians, and they pay doctors time because it takes time, and they say, you've got to take time off your work and come and meet us. And you sit in the guidelines committee reading all these papers, and then we as a group sit together with patients who are on the group, and they write the guidelines. And in fact, they're public, they don't hide these things. So if you do a search on nice.org, you will find guidelines for almost every medical condition being written. You can see the list of who the patients are on the panels and who the doctors are. So it's very, very good. Does that answer that question?
It does, definitely. I think I know, because I've spoken to the person who asked this question, that sometimes it can feel like there's a sort of lack of continuity between how things are done across certain centres, and you know, some things are done a certain way in London and things are done another way elsewhere. And I guess it's, you know, it's reassuring to hear that actually there is a point, you know, however regularly it might be, where everyone comes together and there is that kind of you know, that those discussions, those conversations, and you know, and I suppose again, you know, from a point of reassurance that certain guidelines are followed, because, you know, to hear that things are done very differently elsewhere could be you know, quite unsettling for someone with a condition like this, I guess.
Yes, I think it is important that the rules are followed. They're not always followed in all parts of the world, and the rules are that for MEN1, for example, that centres where more than one patient with that condition turn up is where it should be done, rather than every hospital. We have a lot of hospitals in the country, and so it's been specialised, and things have really improved. Surgeons in particular have been very good at making sure that they don't have a go at an operation once in a blue moon. You know, they get good at one operation. So that has really improved. You will hear of differences. Changes happen and new ideas come about, and then we try it out one centre, and then if that works, we then go and publish and tell other people to try it out. And there's a bit of skepticism sometimes. So, but the outcomes are going to be the same. So there are minor variances that will not change the outcome, but might be a bit more convenient for some people. It depends also what you've got available. So that there are differences in what's available, but the outcomes are all really getting better and better.
Yeah, and I expect that, you know, there's a lot of moving parts to take into account as well with something like this. You know, it's not always yeah, it's not a kind of straightforward system necessarily. So this is I thought a very random question and something I was completely unaware of, so I was very excited to ask it. Someone has asked, why is hair loss common in MEN1 patients, and where does it stem from?
I was unaware that it's more common in MEN1 patients. It's common, okay? It's a common thing in all of us, okay? Male pattern baldness is due to testosterone. It's a normal thing, and I know we all living longer and longer. We want to keep our hair. I don't recommend trying to use medication to keep your hair, because whatever you do in life has got benefits and side effects. And I mean, obviously it depends on what you want, but to me, hair is less important than my health. I wouldn't want to take something to because in theory you could suppress testosterone. I mean, people do this, they take things to reduce testosterone. And loads of other effects on you. So I'm not particularly keen to follow that rule. So hair loss happens to lots of people, and if you look amongst the group, you're going to find it and think, oh, they've all got hair loss. But actually, if you need this is why you need what I like to call in research a control group, because then you realize that they've got it too, and therefore it's not an MEN1 thing particularly. It's linked to age though.
Yeah, it was a very interesting question when I read it, because as I say, I wasn't familiar with that as a symptom of MEN1, but
It's not a feature. It's a feature of blood. So if you have MEN1 and you're a normal person, then you're going to have it too.
Too. Yeah, well, I know we spoke about this, very recently. What actually can we attribute to MEN1, and what is just because it's the human, the human way.
Well, I think that's very important, right? Because if you see a general doctor, a GP, or a physician because of anything else, because all of us are at risk of everything. I might get pneumonia, I might have a heart attack, and you might too. But if you get symptoms of something that's nothing to do with MEN1, the first thing you do is you assume it's MEN1. And then you go and see your GP who thinks, oh, it might be MEN1, bit out of my depth. Whereas if you didn't have MEN1, they'd give you some antibiotics, But because of MEN1, they go, oh, it might be something clever. I'd better not mess with it. And so you get bad normal care. So you need to forget about MEN1 for today. I've got a normal condition. I might have a eczema. I might have hay fever. These are all things that, and the MEN1 shouldn't have a bearing on it, because if it does, you'll get less good care for the other condition. So, and other conditions are really common, and the complicated MEN1 we know about. And so if you haven't got them, you need to not assume it's MEN1 as often as we do. It's tempting.
Very tempting. I know I've definitely fallen into that myself. As I said, I told you, it was crippling exhaustion and fatigue. And after what felt like weeks and weeks of sleeping, I thought it must be something else, and it wasn't. It's really interesting. So on that note, is there a kind of general, a recommendation in terms of the point at which a patient should get to before they, for example, start coming in for, blood tests? Is it a thing of, if you're concerned and you think it's MEN1, come in and get the test done? Or is it kind of actually, sit back and wait and see how things go? Because I think sometimes there's the sort of, this thing of the subconscious fear that sits in the back of the mind of, oh my gosh, this could be my condition. I'm going to go and get something done straight away. But actually that can set off a load of other problems, a kind of a way of thinking, which obviously then takes, adds complication to it, because if it's MEN1, we feel less in control. Whereas if it's something that, it's just going to happen to us because, it's part of life, that feels in some way reassuring. And I think somehow there's there's a lack of certainty amongst patients as to when we need to get things checked up. I mean, what would you recommend if there is a recommendation?
I mean, obviously, because in the case of MEN1, hypercalcemia is so common and it's now, unlike 50 years ago, it's easy to measure. You just tick a box and turn up for a blood test. That's an easy one to do and easy to correct. Or, well, at least you can think about choosing when to have your parathyroidectomy. That's a choice. Prolactin and other pituitary hormones as well are measurable. There is the risk of a false positive. What do I mean by that? What I mean by that is, the particular example that causes trouble is cortisol, right? Cortisol has got all kinds of abnormal beliefs around it, okay? And cortisol is a hormone that goes up in the morning and down in the evening, so it's diurnal. It should be peak at about 8 in the morning if you sleep at night. But if you don't sleep at night, you're a shift worker, then all those numbers don't mean anything. And the problem is, if you do a cortisol in the afternoon, it should be low. That's normal. But if it's low, everyone goes, oh, that's a bit low. Because the reference range that's published is for 9 a.m. if you sleep properly. So if you work a shift and then do it, you're going to get a low number. There's a lot of stuff, and there's a bit of a trend at the moment on things like adrenal fatigue and ways to wake your adrenal glands up. And of course, the adrenal glands are behaving perfectly well. They're under the control of the pituitary gland, and they are responding appropriately most of the time. And trying to make them do a bit more, it is not sensible, because they are very well regulated. Now, of course, if you have a tumor, that changes things of the adrenal gland, because then you start making the hormone abnormally. But normally it does a very good job, and so the adrenal glands don't get fatigued. They make less cortisol appropriately when you're meant to be tired. tiredness is a very important survival mechanism to make us not get too exhausted. So, if you don't feel tired, that's not a good thing. Feeling tired is normal. Sometimes it's not convenient, but it's normal.
Yeah, I think that's really, really important. I'm glad you said that, actually, because it's so amazingly easy to just overthink every single bodily, sensation, anything that happens. It's kind of like, oh, that feels problematic or whatever. And as I said earlier, the brain is only going to try and solve the problem and start, putting all these kind of these things out there which make us think it is a problem when it might not be.
I mean, the endocrine system has got a very beautiful system of negative feedback, and it regulates itself. And most of us don't even know it exists. In fact, most people just go on with life. But if you've got MEN1, you know all about it. And so you're absolutely right. You think that maybe it's not working when actually it's working perfectly well almost all the time. And we know which ones to measure, and we can measure the hormones if we have to. Mostly they're normal, and the problem you have is not linked to your calcium or your prolactin or your growth hormone, but something else.
Absolutely. We're nearly at time, but I have one more question which I want to squeeze in. Again, I chuckled when I saw this one.
Okay.
And you touched on it ever so slightly earlier when you were talking about that feeling of wanting to be able to do something to prevent, the progression of tumors in MEN1. And there is dialogue out there, about, diet, environment, lifestyle factors, all this sort of thing. Someone has asked very specifically about diet and gut health and the link between those two things and the growth of tumors. I presume they might mean pancreatic tumors, just because, that's kind of the obvious one, really. But any of them, from your knowledge and your experience and what you know, is that possible, or is it just not, there's no way?
No, it could be, right? There are some things that we know are definitely a problem, right? So, for example, pancreatic disease of all types is more common in smokers. So that's environment. That's not genetics. That's definitely environmental. If you smoke, we don't actually know what it is in the cigarette. I don't think it's nicotine, and we're all saying, well, vaping might be all right, but I don't know that's the case, right? But smokers definitely have a lot of cancers that we know about in the lung, but surprisingly, it's other ones as well. So that is definitely environmental. And similarly, the environment can, as a consequence, have effects on the pancreas. So alcohol, which is environmental, if you have a large amount of it, often you can get pancreatitis, which then puts you at risk of pancreatic cancer. But that's totally different to the MEN1 situation, which is a neuroendocrine tumor of the pancreas. It still is a cancer, but it's not like pancreatic cancer, which is not endocrine. So endocrine cancers tend to be less aggressive. They're still bad. Pancreatic cancer, the old-fashioned, the non-MEN pancreatic cancer is very, very fatal. It has a very low survival rate, much, much worse than MEN1. And as I said, alcohol is a very clear risk factor for that. So what does that mean for diet? Probably there is a small impact, okay, of different diets, but I don't know what diet to recommend, I'm afraid. I don't know what it is, but I would recommend, I think what my grandmother used to say was, if you have things not to excess, anything is okay in moderation. So I think that's a good summary. And, the other thing that people do, which I think is harmful, is not enjoy life, because they deliberately restrict what they can eat. They don't enjoy chocolate because they think, well, if I have a chocolate, I might get some bad thing. But there's no evidence for that. Coffee was another one that people worried about. Coffee has been studied. Coffee has been shown to not be linked to any bad outcomes. It's not good. They're not good either, but I quite enjoy a coffee. And so I drink it with impunity.
I love that. And I agree, actually, because you wouldn't believe the number of people who come and ask me about things like diet and supplements and all sorts. And honestly, the first thing I want to say is just enjoy your life.
Yeah, that is the most important thing.
Yeah,
and I will say, having control of your life is really quite important for your well-being. So if things are going out of control and there's a way of controlling, even if it's extreme, some people say, you know, I can't do this job because I can't bear my boss, and I can't leave because I need the money. So that's tricky then, because then you're stuck. And if you're stuck, then you're out of control because you're not controlling your surroundings. So that's unfortunate. So things can leave you out of control, and that will make you feel unhappy. So think of ways to take control of your situation is my recommendation.
Absolutely. Yeah, I like to think of it as, you know, take control of what I can take control of and let go of what I can't. And that's a journey in itself, realizing what you can and can't control.
Yeah, absolutely right.
Definitely. Well, thank you. That was an interesting answer to that question, actually. And yes, I don't think anyone's actually I don't think anyone asked about a specific diet necessarily, but obviously it's a huge buzzword now, and there's no point almost ignoring the conversation. It's like, actually, how can we bring some, you know, some truth and some proper kind of backing into this sort of thing? So I think that answer will be appreciated a lot.
Yeah. There's lots of different arguments for different diets, and people swear by one or the other. And they're both right. They're all right. I mean, some people say you must avoid sugar, and therefore you've got to have Diet Coke. And others say, oh, the additives are really bad for you, mustn't have the additives. Both of those are not evidence-based. I think anything in moderation will be all right.
I agree. I like the moderation argument, definitely. Absolutely. Moderation and variation, my grandma used to say.
Yeah, quite right. Quite right.
Super. Brilliant. Thank you, Karim. I'm going to stop the recording.
Okay, absolutely fine. Thank you very much.